Stenosis of the middle third of the right internal jugular vein, IJV, presents unique challenges, particularly when evaluated through ultrasound and Doppler imaging techniques. In grayscale imaging, the affected portion appears distinctly narrowed and tapered, often indicating impaired blood flow. The proximal segment of the vein may exhibit mild dilatation, a compensatory response due to reduced outflow. Importantly, this case does not reveal any thrombus or mass lesions that could complicate the diagnosis. Color Doppler imaging adds another layer to our understanding by showcasing a reduced luminal diameter at the site of stenosis, where blood flow velocity significantly increases, often accompanied by turbulence. Interestingly, distal to the stenosis, flow can remain pulsatile, suggesting that compensatory mechanisms may continue to function adequately despite the narrowing towards the middle third of the vein. Further insights are gained through spectral Doppler imaging, revealing continuous forward flow at the stenotic segment. Here, the typical phasic pulsatility is noticeably absent, typically associated with the IJV, due to lost normal transmitted cardiac and respiratory variations. The flow proximal to the stenosis demonstrates normal pulsatility, hinting at possible venous congestion, while distal flow may appear normal or slightly diminished, contingent on the severity of the stenotic segment. Differential diagnoses are essential for accurate assessment of the stenosis. Fibromuscular dysplasia introduces non-inflammatory, non-atherosclerotic narrowing, characterized by multiple stenotic segments on imaging. Alternatively, external compression by adjacent masses or chronic venous thrombosis with recanalization informs treatment approaches. Moreover, congenital anomalies could play a role, as could inflammatory processes such as vasculitis or phlebitis, leading to potential narrowing of the vein. The prognosis remains both complex and dependent on severity and underlying causes. Mild stenosis with unimpeded flow typically forecasts a positive prognosis, while severe stenosis raises concerns such as intracranial venous hypertension and increased thrombosis risk. Symptoms like headaches and neck discomfort may emerge if cerebral drainage is compromised, presenting the necessity for collateral formation as a response to chronic stenosis. Management strategies primarily focus on observation for asymptomatic patients with mild stenosis. However, for those at high risk of thrombosis, anticoagulation may become crucial. Interventional procedures like angioplasty or stenting may be warranted for more severe cases, while surgical intervention remains an option when external compression or mass lesions are involved. Ultimately, addressing the underlying cause will be essential to prevent recurrence and enhance patient outcomes.